was off. Here we go. All right. Don't forget to take the mask off.
Hello, welcome everyone to today's Endocrine Grand Rounds. We are very pleased to have one of our own Pediatric Endocrinology faculty, Paul Hiers, talk to us on Endocrine Emergencies. Paul grew up in Florida, went to medical school, undergraduate, residency and fellowship at the University of Florida, and developed an interest in pediatric endocrinology in areas of diabetes and other aspects of pediatric endocrinology, and has been here for just over a year. And we all enjoyed his lecture last year, and today he's going to talk to us about endocrine emergencies. Paul? Mm-hmm.
Thank you. Thank you for that warm welcome. So it's nice to finally meet you all. I gave my lecture last year, but it was virtual, so it's kind of weird giving an in-person lecture again. This is the first one I've given in probably like 2 years. Today we'll be talking about endocrine emergencies. Most of us chose the field of endocrinology. We have a nice lifestyle. We can do a lot of things from home. So we have some emergencies, but luckily we have emergency colleagues. We got ICU colleagues that can kind of take some of the brunt of some of the emergencies. But there are a few things that we need to help them out on, and so things we should be up to date on. So, all right. There we go. I have no disclosures, no conflicts of interest. Today's talk will be focusing more on the endocrine side of things. Even though probably a common emergency that we have is DKA or HHS, that deserves a talk in and of itself, and wouldn't be doing its service to talk through it really quickly during this type of lecture. So we focusing on some other aspects of endocrine emergencies, specifically acute adrenal insufficiency, hypo or hypercalcemia, and then thyrotoxicosis. We'll formulate the differential diagnosis for each, describe Thyroid Storm and its acute management, and then just discuss some of the clinical treatments. This talk is meant to be more on the clinical side, so there'll be doses and medications, and so you guys are happy to have access to my PowerPoint. So if you need a reference to look up, calcium drip levels, or even more interesting things like sodium iodine infusion level, like, you're welcome to have access to them. So, all right. So we'll begin with acute adrenal insufficiency. I'll start with an anecdote. So when I was in fellowship, you get called at night and you hear a story that makes you think of, Addison's disease, something that we typically think of a lot of. It was a 15-year-old girl. She'd been bounced around to multiple hospitals over the last couple months, where she'd come in and have some low sodium levels. They'd give her a fluid bolus. She'd get better. She'd go home. And this had been going on for a couple months to years. And then they call you with kind of the story. And this is the first time. It was after about the 5th ED admission. They finally called endocrinology. No one checked the cortisol level before. Someone finally thought, well, maybe this could be endocrine. I talked to them on the phone. It's like midnight. And I'm asking them all the questions. Oh, she's been fatigued. She's been throwing up. Sodium's low. Potassium's high. And I asked them, what does she look like? Does she have hyperpigmentation? No, she's not hyperpigmented. She looks fine. And so I'm still worried that it's adrenal insufficiency, so we treat her. Walk in the next morning, see her in the PICU, and she's dark. Her families is Irish, and she's looks like she's from South America. And so I went back to that resident who was actually a friend of mine. And I was like, you gotta be kidding me. This is hyperpigmentation. This is the diagnosis. This is what you need. So it was a fun story to tell after the fact. But we've probably all been there where we've seen a patient and you're like, wow, they can be quite hyperpigmented, especially when it's been going on for some time. So acute adrenal insufficiency occurs when the adrenal cortex fails to produce sufficient glucocorticoids and mineralocorticoids in response to stress. So that's a simple definition. We all are aware of the adrenal physiology here. So you got the hypothalamic pituitary adrenal axis. So through you have different positive feedback and negative feedback involved. So the hypothalamus is producing corticotropin releasing hormone, CRH, goes to the anterior pituitary, which actually makes POMC, which eventually cleaves into ACTH, which acts on the adrenal cortex, producing cortisol. Cortisol and ACTH will feed back on the level of the pituitary and the hypothalamus to keep everything in check. So it's your classic endocrine feedback loop. There's different other things that can affect ACTH and CRH levels, including stress, emotional stress, hypoglycemia, cold exposure, pain, as we know as well, and medications can as well. Not to go too deep into our adrenal pathway, but as an endocrinologist, we're all very familiar with this. So you have your zonas, glomerulosa, fasciculata, and reticularis. Different people remember it in different ways. You got like GFR, the salt, sugar, and sex pathways for the adrenal gland. Glomerulosa is responsible for your mineralocorticoids or your salt hormone metabolism. Fasciculata is responsible for your glucocorticoids, end up producing cortisol or your glucocorticoids, and then your zona reticularis, which is important for your sex steroids. We're not going to go through all the pathways because it's another talk in and of itself. But the things to remember is, especially the mineralocorticoid pathway, is not under the control of ACTH. It's under the RAS system, the renin-angiotensin system. So that's important when we're discussing acute adrenal insufficiency because it's the glucocorticoid pathways that's under control of ACTH. Causes of adrenal insufficiency. So like many endocrine disorders, we're breaking them up between like primary and secondary. Primary causes, congenital adrenal hyperplasia, autoimmune disease, tuberculosis, meningococcal septicemia, known as the Waterhouse-Friderichsen, or adrenal hemorrhage from some type of trauma or mass blood loss. Secondary causes or central causes, you can have suppression of ACTH by exogenous steroids or iatrogenic adrenal insufficiency. This is the most common cause of adrenal insufficiency that we all see. It's from us treating other disease processes with steroids. You can have pituitary or hypothalamic tumors, any type of CNS surgery or radiation, structural abnormalities such as like septo-optic dysplasia or congenital hypopituitarism can cause secondary adrenal insufficiency. So when it comes to acute adrenal insufficiency, patients can have adequate glucocorticoid production for ordinary metabolic demands, but are unable to handle increased amounts of stress. And so they become ill, they become sick, they undergo a surgery, anesthesia, and that's what can push them over the edge. Glucocorticoid and adrenal androgen production are impaired both in primary and secondary adrenal insufficiency, but the mineralocorticoid activity is preserved in secondary adrenal insufficiency. And so when it comes to the acute management and talking to your ICU colleagues, what type of steroid they use is important. So lots of times they should be using like hydrocortisone, which isn't going to be a problem. Sometimes if they would be trying to be using dexamethasone, that might be okay if they have secondary adrenal insufficiency, but if they have primary adrenal insufficiency, dexamethasone doesn't have any mineralocorticoid effects. So hopefully they're on salt-containing fluids, but that's a consideration to think about and why that matters. Presentation of an adrenal crisis. So it depends on if your symptoms are more from glucocorticoid deficiency or mineralocorticoid deficiency. Thinking more of the glucocorticoid effects, so the typical things we think of: weakness, fatigue, anorexia, weight loss, vomiting. You got mental status changes, and it can be from hypoglycemia. Mineralocorticoid deficiency will lead to dehydration, hypotension, salt craving, and then without intervention, it can eventually lead to shock. Emergency management. From an endocrinology standpoint, it's pretty easy. You got to give them steroids. If suspicious of diagnosis, you have to treat. It is an emergent condition. It can lead to death. You got to treat them and figure out later. Hopefully your emergency colleagues will draw a little bit of blood for you and get a cortisol and ACTH level before they give steroids, that you can hopefully come up with a diagnosis after the fact. But if they're in the ED dying, not looking really good, you have to save the patient. Fluid resuscitation is priority. IV access with large gauge needle, get stat electrolytes, glucose, obtain a cortisol and ACTH, because that can give you lots of information. You're not going to get those immediately back, especially the ACTH, but after you've saved the patient and got them stabilized, it'll help you come up with a diagnosis. And then you treat the shock with, normal, with fluids, and then you repeat as necessary based on ABC's resuscitation. You treat immediately with 75 to 100 milligrams per meter squared of hydrocortisone IV, and then you repeat this every 4 to 6 hours until stabilized. This is for like acute management. They're in adrenal crisis. They're super sick. The thing to remember is with the Solucortef or hydrocortisone, about 20 to 35 milligrams of Solucortef has a mineralocorticoid activity approximately of 0.1 milligrams fluorinef. So if you're given large doses of hydrocortisone, you're actually giving them some fluorinef. As you guys know, like fluorinef is only given as a pill, so you cannot give fluorinef as an IV. Luckily, you're getting to the same effect by giving them salt-containing fluids, and so you're doing the job of fluorinef in a way by giving them salt-containing fluids. But if you're giving them stress dose steroids at large amounts, you're having some mineralocorticoid effect that's helping them as well. Steroid potency charts, these can be debated, so don't knock me for like the ranges. Every literature has like a little bit of different ranges, but everything is compared to cortisol. And so hydrocortisone gets converted to cortisol. That's our hydrocortisone equivalents that we're using. Hydrocortisone has glucocorticoid and mineralocorticoid effect. Prednisone and prednisolone do as well, so does Solumedrol. The one to remember is dexamethasone doesn't have any mineralocorticoid effect, and so that may be a choice, especially in the ICU, where sometimes they're not thinking about their steroid choices sometimes. And then the glucocorticoid effect, these are sometimes debated, but typically prednisone is 4 to 5 times, same with prednisolone. Why there's a range in the literature is from a pharmaceutical side of things, pharmacodynamic side of things, there's the kind of anti-inflammatory effect of the steroid and then the growth effect. And so that's why there's a big range, because some of it's causing true anti-inflammatory effect and some is causing growth arresting effect. And from an endocrinology standpoint, we're more interested in the growth arresting effect because we think that is more reflective of kind of its effect on the adrenal axis. And so dexamethasone is very potent, and so, but also why we see why the more potent type of steroids can cause iatrogenic adrenal insufficiency, because they have long half-lives, they're very potent. It puts the adrenal gland to sleep. After they're stable, so you're going to continue IV fluids for the next 24 to 48 hours, replace their fluid deficit, and then you have to evaluate the cause of the adrenal insufficiency if it's unknown. And then you continue glucocorticoid replacement at stress dosing. I always found this interesting that, in the literature, it's 36 to 50 milligrams per meter squared per day of hydrocortisone equivalent. But then if you look at the guidelines, they always just say sometimes like 3 times physiologic. Depending on your physiologic dose, which is sometimes 8 to 12, like if you're on 8 mg per meter squared per day and you triple it, that's still only 24. So you're not truly at stress dosing. Like the guidelines for CAH, they don't always put the 36 to 50. I was taught I always err on the side of, if they're really sick, you want to give them extra steroids, because if they're trying to die of adrenal crisis, what's the harm? If you give them too little, there could be problems. So I tend to always calculate the stress dosing just to make sure it's in the 36 to 50 range. Not that I've ever seen anybody triple their stress dose and it only reached 30, and I've never seen them run into problems. But I always just think that's an interesting thing in the literature where we know that stress is 36 to 50, but then if we say triple it, it's not always 36 to 50. And then you taper the glucocorticoids down to maintenance dosing, which is somewhere between 8 and 12 milligrams per meter squared per day. And then afterwards, depending on the cause, if it's primary, they will need mineralocorticoid replacement with fludrocortisone when the normal saline is stopped. And then all of the patients with adrenal insufficiency should have a medical alert bracelet letting someone know that if they're found down, they need emergency steroids, and then teaching them about subsequent febrile illness, trauma, stress, or surgery, that they're going to require cortisol replacement. And then all patients with adrenal insufficiency should go home with a Solu-Cortef emergency kit. And so when I describe it to patients, I tell them it's kind of like an EpiPen for steroids. So you don't know when you're going to get stung by a bee. You have your EpiPen. You don't know, like, if you get hit by a bus or some type of emergency where you're going to need Solu-Cortef to keep you alive until an ambulance gets there and you get IV access and they can give you steroids. All right, that's adrenal insufficiency. Again, this is focusing more on like the clinical acute management of these things. So yeah. Hypocalcemia and hypercalcemia. So some of the physiology, derangement in calcium homeostasis occurs when, so there's multiple different reasons for this. It can be due to protein binding, and chelation alters the availability of ionized calcium. So as we know, more than half of the total serum calcium is protein bound. And so depending on our pH status, or acidosis or alkalosis can affect the binding of our ionized calcium. So alkalosis increases the binding and decreases ionized calcium. And then acidosis decreases binding, thus increasing ionized calcium. There can also be other metabolites around. So if you have hyperphosphatemia, there's extra phosphorus around that will bind up your calcium and can falsely lower your calcium level. Well, it doesn't falsely lower, it just is binding it up. The other thing that hyperphosphatemia can do is it inhibits 1-alpha hydroxylation, which can be counterproductive when your calcium level is going low. Other causes can be excessive or deficient hormonal action, and so our calcium is under the control of parathyroid hormone, PTH. PTH release varies with calcium level. It can be inhibited by hypomagnesemia or hypermagnesemia, for that fact. And PTH is also inhibited via a feedback loop by activated vitamin D, 125. I have the vitamin D pathway on the next slide. Calcitonin is also a player here. It's produced by the C cells in the thyroid. Its job is to lower calcium levels by inhibiting osteoclasts and promoting calciuria. But in humans, it's thought to be much less effective at doing this in the grand scheme of things as PTH. So it's biologically there, but it just doesn't seem to be playing a giant role in our lives. So there's conditions where, like, you don't produce calcitonin and you're not having issues with your calcium levels, or if you're having a calcitonin producing tumor, like, your calcium levels really aren't that altered as well. So it's an interesting medicine. It is used clinically to treat some things, but there's an interesting effect with calcitonin. It has tachyphylaxis. So, like, the more you give it, the less effect it's going to have. So it's kind of a short-term solution to some things where after 24 to 48 hours, it's kind of lost its effectiveness. So PTH pathology. So parathyroid glands, they make PTH. Your parathyroid glands via the calcium sensing receptor will sense a low calcium level and then thus increases PTH secretion. PTH acts on the bone to release calcium and phosphorus. It also acts on the kidney to decrease excretion of calcium. It also, via 1-alpha hydroxylation effect, will increase calcitriol formation. And then the calcitriol acts on the bone to have a similar effect as PTH. But the main effect of calcitriol, 125 activated vitamin D, is on the gut and it increases your absorption of dietary calcium. Thus, all these processes are happening with the goal of raising your calcium level. Hypocalcemia symptoms. So some of the CNS effects can include tetany, convulsions, seizures. You can get carpal pedal spasms, muscle cramps, twitching, paresthesias. Typically, you can get them like perioral. You can also get them in your fingertips and toes. And then in infants, you can get laryngeal stridor and apnea, which can sometimes be the presenting symptom for hypocalcemia for some of our children. So the classic kind of signs they teach us all. So you got I'll probably butcher the name, Shopstick sign. So it's the facial muscles on the same side of the face are contracting momentarily due to hyperexcitability of the nerves. So you're tapping on the facial nerve and you'll see a kind of a twitch in the corner of their mouth. There's the trousseau sign. So I've never done this one. My attendings told me it was very mean to ever do this to someone, so you should never do the trousseau sign. But basically, you puff the blood pressure cup above systolic and leave it there for 3 to 5 minutes, and then eventually they'll develop a carpal pedal spasm, and it just is super, super painful. So I think these were probably important back in the day when we didn't have access to labs, and nowadays our PTH comes back very quickly, our calcium levels come back very quickly, so it's that whole concept of the physical exam is dying because we have labs available so immediate now. And so, I don't know. If anybody's done the trousseau sign, let me know and tell me how it went. I'm sure it's pretty cool to see. Hypocalcemia symptoms can also involve cardiovascular symptoms, hypotension, even leading to myocardial depression, congestive heart failure, arrhythmias. So very serious. Long-standing hypocalcemia, dermatologic signs can include dry, coarse skin, eczema, brittle hair, brittle nails, dental enamel hypoplasia. And so what are the different causes of hypocalcemia? So broadly, it can be due to changes in calcium binding or chelation. So if you're alkalotic, if you have too much phosphorus around, if you got a transfusion. So if the citrate used to preserve, used in packed red blood cells will bind up your calcium and cause a lower calcium. Other causes can be due to reduced PTH effect, whether this is gland failure because they are born with hypoparathyroidism, insensitivity, so they have hypoparathyroidism. It just the PTH doesn't work because the receptor is broken. Or suppression of PTH release. It can be due to reduced vitamin D effect. So if you have vitamin D deficiency, it can ultimately lead to hypocalcemia, even though it's a late effect. Impaired action of vitamin D. So again, vitamin D resistance. Vitamin D is not working because the receptor is broken. But different drugs and toxins can affect your calcium level as well. So lithium is a big one. That's the big one everybody knows about, but it looks similar to it interacts on the PTH receptor, so that's the big one that we'll see.
Some diuretics and some anti-cancer medications.
Yeah.
There's a whole group of other some antibiotics. I think
there's a whole list. Yeah. So it's always good if you see a kid you have to pull up. I think there's one on UpToDate that has kind of all the drugs that have some effect on calcium, especially. We don't typically have to worry too much in kids because the kids aren't on too many medicines. But sometimes with adults, they've got polypharmacy and lots of different medicines. And could that be what's causing some of these issues? And then, ultimately management. So asymptomatic hypocalcemia, if they're asymptomatic, you can treat them with oral calcium. Typically, you're using calcium carbonate, just Tums, as your replacement agent. Typical kind of replacement doses is somewhere between 45 to 65 milligrams per kilo per day of elemental calcium. And so I have the chart of the percentage of calcium for the different calcium substrates that you can use. And then you divide it either TID to 4 times a day. Calcium, like when you intake it orally, you tend to excrete it pretty quickly. And so that's why it really needs to be, can't just do it twice a day. It needs to be closer to 4 times a day to get a real steady state. Symptomatic or critically ill people with hypocalcemia, different things you can use, but like calcium gluconate is one of them. The dose, depending on if you're on the kid side, it's on the lower side. If you're an adult, it can be up to 60 to 200 milligrams per kilo per dose, again, elemental. And then maintenance, you can do somewhere between 10 to 50 milligrams of elemental calcium per kilo per 24 hours, given as a continuous infusion. Cardiovascular and neurovascular collapse, so they're really, really, really sick. You got to give them calcium immediately. So you're giving them 20 milligrams per kilo per dose of calcium chloride over 5 to 10 minutes. There's always a risk with giving calcium. And so typically you want like a central line to be able to give it, but the risk of rapid treatment includes bradycardia and asystole. You may have to treat with atropine. But then there's always the risk of extravasation. So like if you don't have great access and it's going in a peripheral line, you can cause a calcium burn, which they can be quite disfiguring. So depending on the formulation of the calcium, there's different percents of elemental calcium. So I put in red the ones we tend to use probably the most. So calcium carbonate, Tums, is what we use outpatient a lot because it's cheap, it's easy to use, and it's the highest percentage elemental calcium that you got. So you're getting a lot of bang for your buck. So it's 40% calcium. The things that you're treating with, so you're either using calcium chloride typically or calcium gluconate. Calcium gluconate's only 9% calcium. So it's a lot, there's a lot of fluid behind it. That's important to consider because sometimes if you're treating them, so if you're overhydrating the patient, they can kind of lower the calcium level as well. And so with calcium gluconate, you're kind of giving a lot of fluid with that calcium. And so just something to kind of have in mind. Calcium chloride is more potent, but if you're given that centrally, it can work a little bit better, but is again that risk of extravasation can be increased if you're giving it through a peripheral. And then there's different formulations that you can use too, but I highlighted the ones we use the most. And then always with the management of hypocalcemia, you can't forget about the magnesium. So sometimes we're focused on the calcium level, but we'll forget about the magnesium. So if the magnesium is low, they're not going to get better eventually. Like you're going to have to treat them somehow, but you need that magnesium level there because otherwise it could be impairing PTH release. So if you're treating a symptomatic kid, you want the magnesium level above 1.5, and then you can give them IM or IV magnesium sulfate. That can always be tricky because you're like, why is this kid still low? Like his calcium level is not coming up, despite like it should be getting better. And then if you didn't check a magnesium level, that could be why it's not getting better. And then moving on to hypercalcemia. So signs and symptoms. So these are the stones, bones, groans, psychologic overtones that we all learned back in medical school. So renal, you can have polyuria, reduced urine concentrating ability, dehydration, kidney stones. GI, you're going to get constipation, not a great appetite, abdominal pain. You can even get calcium deposition in other organs that can be picked up via X-ray or other imaging, just incidentally. Cardiac causes can be hypertension, shortened QT interval, arrhythmias. CNS, you can have hypotonia, hyperreflexia, paresis, lethargy, and over time it can lead to confusion and even coma. Etiology of hypercalcemia, so can be due to different things. This is not an all-inclusive list, but some of the bigger ones. So you got increased bone resorption, so hyperparathyroidism, malignancy, you're producing PTH-related peptide, hypercalcemia immobilization. At least on the pediatric side, I feel like we don't see this as much anymore. I think our ICUs are doing a really good job at kind of moving the patients with PT, but like, I don't know. I've treated a couple kids with bisphosphonates for immobilization. But it just seems like from when I was even in fellowship, like we used to get consulted all the time and to pick you for hypercalcemia immobilization. And then by the end of my fellowship in here, like it just doesn't seem like we see it as much. So it's probably a kudos to our PTs that are just moving our sick patients more and more to prevent this. Thyroid toxicosis can cause hypercalcemia as well, as can vitamin A intoxication. The etiology of the vitamin A intoxication is interesting, but I think it actually leads to like bone resorption as like the cause of why it causes the hypercalcemia. It's like an interesting mechanism. You wouldn't initially think that, like, what does vitamin A have to do with bone stuff? Other causes can be due to increased intestinal calcium absorption. So this is vitamin D intoxication. There was like a New England Journal case a couple months ago where it was a vitamin D intoxication, but he was like, it took like 2 years to develop, and he was taking like, for some reason, he was taking like 50,000 units daily for like 2 years before he eventually developed symptoms. And it was just impressive because they said like, oh, like his like combined dose of vitamin D over the last 2 years was like 6.2 million units or something like crazy. But it still took him like 2 years before he finally was presenting with hypercalcemia. I just thought it was really impressive that it kind of took that long and then I couldn't remember from the article, but I was like, how did he get his hands on like 50,000 units of vitamin D every day? And I don't know. So I can't even get my my vitamin D deficient patients to take their 50,000 vitamin D like weekly for a couple of weeks. So any granulomatous disease can cause increased absorption, and the sarcoidosis and other granulomatous disease, even leprosy, it's caused by an increase in 1-alpha hydroxylation, and so it leads to more 1-activated vitamin D, and so that leads to increased calcium absorption. Williams syndrome, we had a Williams syndrome on the pediatric side a couple of weeks ago. It was a 9-month-old, kind of failure to thrive, came into the ED, calcium level was 16, and he kind of looked a little different to the ED fellow, and they got some labs and the calcium was 15, the PTH was like less than 1. So we knew this wasn't hyperparathyroidism, and so we started kind of going down the pathway of, well, what else could this be? It's Williams syndrome, the etiology of like why they get the hypercalcemia is kind of unknown. They get it and then it self-resolves in toddlerhood. And so it's just kind of, you treat them. He responded very well. We just gave him fluids overnight and at 2 times maintenance, and by the morning his calcium level was down to like 11 or 12. And then there's a specific formula that we use in Williams syndrome. It's called Calci-Low. So it's a low calcium formula. And then he went home on that, and I've been following him for like the last 6 months, and his calcium levels are like 10 to 11. And then basically you follow them and you slowly introduce new calcium foods over time, and you check a calcium level, and you kind of wait to see when their hypercalcemia resolves. So it's interesting. Other causes can be abrupt glucocorticoid withdrawal or deficiency, milk alkali syndrome, so just having a ton of calcium through ingestion, and then decreased renal excretion of calcium. So this is the one we think of. This one's not an emergency, but can sometimes show up with the familial hypocalciuric hypercalcemia syndrome. So they just have an inactivating mutation in the calcium sensing receptor. So they just think that their calcium level should be kind of in that 11 to 12 range, and their body's not doing anything different. Sometimes they'll show up to you incidentally. So they'll be in the emergency room for some other reason, because they typically don't really have too many acute symptoms. And then you're going to try to fix them, and you can't. And so you're going to cause more problems by trying to fix them. Within the pediatric realm, if there's the familial form is typically caused by a heterozygous mutation. If you have a homozygous mutation, it'll present with something called neonatal severe hyperparathyroidism. So you just have a really, really broken calcium sensing receptor, and they'll present with calcium levels in the 18, 20 range. And the treatment for them is emergent parathyroidectomy. So there's one kid I had during fellowship that was born and calcium level was like 21, and there was, and you guys probably have more experience with this medicine than we do in pediatrics, but the calciumimetics, the Sensipar, there was like a case report where they like used the Sensipar in a kid with this condition, mimicking the effect of calcium to try to lower the PTH levels, and it was just used as like a temporizing measure to get them to surgery. So it's interesting.
Is it related to one untitled?
No, it's at the bone. Yeah, it's at the level of the bone on the osteoclast. Like steroids. That could be part of it too.
Because many of your adrenal insufficiency sometimes can present with mild hypercalcemia.
Mm-hmm. Yeah.
But I'm not sure. It could be both.
Yeah, it could be both. And then acute management of hypercalcemia is hydration. So you're giving them lots of fluids, somewhere between two to 3 times maintenance. And then you want to treat the underlying cause. And so depending on what that is, it depends. If it's severe and they're symptomatic, there might be other agents that you can use. So Lasix has been used in the past, so it induces calciuria, so you're just getting them to pee out extra calcium. Remember though, if you're going to use Lasix, you want to make sure that their fluid status is improved and you replace their fluid deficit. So you're given Lasix, which is a diuretic, you're going to dehydrate them. Usually when they come into your emergency room, they're already going to be dehydrated because of the hypercalcemia and they've already been peeing a ton. So if you use Lasix, you want to do it after you've given them a fluid bolus and you kind of make sure their fluid status is appropriate. Other agents you can use is bisphosphonates, pimidronate, or zolindronate can be used. It inhibits bone resorption. Calcitonin, like I was telling you, it can be used in hypercalcemia, 2 to 4 international units per kilo. It's given IM or sub-Q. It inhibits PTH at the bone, but it has that tachyphylaxis effect. So it's only going to be helpful for you for 24 to 48 hours, and then you're going to see diminishing effects. So it's just a temporizing measure. And then you can also use doses of glucocorticoids as well. And it decreases vitamin D-mediated calcium and phosphorus absorption from the intestine. So like the glucocorticoids at the gut is blocking calcium absorption. Yeah. Making sure I'm doing good on time. All right. Thyroid Storm. That's a great name. Sudden release of thyroid hormones, which results in uncoupling of oxidative phosphorylation and increases lipolysis. And this will result in increased thermogenesis, increased insensible fluid losses, and increased metabolism. Thyroid storm stats, and my data is mainly in kids because I'm a pediatric endocrinologist, but thyroid storm it's a rare occurrence in children. It occurs in less than 1% of all people with hyperthyroidism, but the mortality rate is very high, 20% and maybe even higher in newborns. Neonatal thyroid toxicosis occurs in 1 to 2% of neonates born to mothers with Graves' disease. Infants younger than a year constitute only 1% of childhood thyroid toxicosis, though. So it's a very rare event, but can be deadly. Most cases, so more than 2/3 of all the cases of thyroid toxicosis occur in children aged 10 to 15. And so these are our patients where they're kind of non-compliant. So it can be a combination of different effects as to like why they're in thyroid storm, but sudden cessation of their methimazole can be a contributing factor. And so it can be due for various reasons. So it can be just due because you have Graves' disease, and that's rarely can be like your presenting symptom. They can be caused by transplacental passage of the maternal thyroid stimulating immunoglobulins and neonates, and so that's that neonatal thyrotoxicosis. All mothers that have Graves' disease usually are checked in the late second to third trimester for thyroid stimulating immunoglobulin antibodies, and it tells you your risk in the neonate. So if mom's antibodies are completely negative, you're not worried about the child. If hers are positive, there's an additional algorithm for checking that child in the first couple of days of life and then a couple of weeks later to see if they're developing any symptoms. It's usually a transient effect, and so these kids don't typically have true Graves' disease. It's just from the maternal antibodies passing over, hitting the receptors on the child's thyroid, but it can take a couple months sometimes for those immunoglobulins to get out of the system. Mucin-Albright syndrome with autonomous thyroid function can lead to thyrotoxicosis. You have a hyperfunctioning thyroid nodule, hyperfunctioning multinodular goiter, or a TSH secreting tumor. These can be other causes of thyrotoxicosis as well. There's typically, though, sometimes a precipitating factor. So yes, you have to have something that sets you up for like having Graves' disease, but then sometimes something can kind of push you over the edge in a sense. And so it can just be an intercurrent infection. So you get the flu, you get COVID, and you haven't been in really great control with your Graves' disease. That can put you into thyroid storm. Trauma, there's even been reports of vigorous palpation of of an enlarged thyroid gland has pushed someone into thyroid storm. Or if you just have a big goiter and you're playing football and you get hit in the neck, that can kind of cause a sudden release of lots of preformed thyroid hormone and precipitate a storm. Thyroid surgery in an inadequately prepared patient with hyperthyroidism, sepsis, anesthesia induction, giving radioactive iodine, different drugs, pseudoephedrine, salicylates, NSAIDs, different chemotherapy. Again, if you're taking too much thyroid hormone, commonly what we see is withdrawal or noncompliance from their antithyroid medications. There's been reports of diabetic ketoacidosis precipitating it, and even be we had a case in fellowship, and I think I was a resident still actually. They presented with DKA, and they were really, really sick, and we couldn't figure out why they had a fever, and they were getting worse, despite their acidosis kind of getting a little bit better. And then finally, the thyroid screening labs that we got, a day later, the TSH was super suppressed, and the free T4 was 6. And we're oh gosh, she's in storm. So sometimes you have to have a high index of suspicion for these thyroid storms because they can look like sepsis or they can look like DKA. It doesn't always, you're not always thinking that this is thyroid storm because it is a rare event. And then pregnancy can do it too. Hyperthyroid symptoms on its own. So you can have nervousness, palpitations, increased appetite, weight loss, goiter, thyroid eye disease, hypertension, diarrhea, mania. Those are your typical things you think about with hyperthyroidism. Thyroid storm is another level. It is a clinical diagnosis, and so you have to think of these things. So it's typically you have hyperthyroidism, but plus you have some type of end organ decompensation, which that's the kind of the cutoff for determining that it's storm. And so fever can be quite aggressive, flushing, tachycardia, arrhythmias. They have increased anxiety, severe abdominal pain, diaphoresis. But without identification of this, it can lead to coma, cardiovascular collapse, and death. There are different kind of point systems you can use to kind of help figure out if there is a suspicion for storms. Is the Birch-Witorsky point scale, and so depending on your level, so you get different points for temperature, cardiovascular dysfunction, CNS, heart failure, GI symptoms. Depending on your score, it kind of just helps you decide if you think this is storm or not. If they're 45 or greater, this is storm, and you got to treat them accordingly. if they're in that 25 to 45 range, you have to use your clinical judgment and assess the patient to help you decide if we need to start treatment or not. Laboratory tests you're going to see, so the free T4 is going to be elevated, the total T3 is going to be elevated, the TSH should be suppressed, and then typically if it's Graves' disease, you're going to have your Graves specific antibodies such as your TSI, TBII, TPO, and thyroglobulin antibodies. So your typical like Hashimoto antibodies are typically positive in your Graves' disease patients as well. Acute management, so a lot of the initial stuff is just ABCs, supportive care, trying to correct the hypovolemia, replace electrolytes if needed, control the glucose, controlling the fever with antipyretics. They need cardiac monitoring, and then different agents you can use. Methimazole is something you're gonna want to use, but it's not gonna help you out for the first 48 hours. So it takes time for it to kind of build up in the system. But you need to start it for long-term planning because they have Graves' disease or hyperthyroidism, so you have to control them somehow. Interestingly, if it's a severe illness and you're not quite sure they're going to be able to like swallow by mouth, you can like whip it into a slurry and like drop it down like an OG or a NG tube to get it in for the dose. Other agents we're used to using, so like you got different forms of iodine. So you got Lugol solution or SSKI or supersaturated potassium iodine. And so it's an interesting effect. So you got that large dosing of iodine inhibits release of preformed hormone from the thyroid and then acutely impairs thyroid peroxidase activity, thus slowing the synthesis of new T3 and T4 through that Wolff-Chaikoff effect. They love to ask you on the UofL boards, I'm sure about that, at least on the peds what they do. I'm sure they ask you about Wolff-Chaikoff and Job-Basedow all the time. It's preferably given after MMI. There can be an initial increase in thyroid hormone production when you give them iodine, and so that's always the concern. The dose of Lugol solution, you always look it up, but it's typically like 5 to 6 drops orally every 8 hours. If they're unconscious, they're intubated, they don't have an NG, you can give IV sodium iodine, and so for the same effect. And so that's always an option as well. Other things you're using, so like your beta blockers, either propranolol or atenolol, is used to treat the exaggerated adrenergic symptoms from the hyperthyroidism. It also inhibits conversion of T4 to T3 as well, so there's a bonus effect there. Dose is somewhere between 1 to 3 mg per kg per day divided Q6 or Q8. That's probably one of the most important ones you want to start them off with to get them under control. As you kind of notice, like when it's Thyroid Storm, you're kind of the kitchen sink because they're super sick, so you're trying to do everything you can to get them out of storm because it just has such a high mortality. Hydrocortisone or dexamethasone can be used as well. And then it also inhibits conversion of T4 to T3 as well. And then the dose is up to like 100 milligrams every 6 hours. So you're giving them everything you can to kind of get them safe and through storm. We use the same agents in neonatal thyrotoxicosis as well, so just at littler doses. But it is a life-threatening neonatal emergency. 10% of infants born to mothers with Graves' disease have increased thyroid hormone. But again, like it only occurs in 1 to 2% of neonates born to mothers with Graves due to that transplacental passage of the thyroid-stimulating immunoglobulin. Mothers can have active or inactive Graves' disease. So it's always important for our OBs to ask, why are they on levothyroxine? So if they had an ablation or had a surgery years ago, and sometimes our colleagues don't always think about that. They're like, oh, they just have hypothyroidism. Well, actually, they have Graves' disease that's been ablated, but they still can produce the antibodies years and years later. So, and then all mothers should have like the TSI levels done at the end of second trimester, and there's an algorithm. So if they're over a certain kind of threshold for their TSI, you're going to be worried about the infant, and so they're just going to need to be checked. The neonatal thyrotoxicosis, the onset is typically day 2 to 9 of life, so it's not immediate. Sometimes we've picked up kids where their newborn screen will be a little bit abnormal, and so that will kind of cause a follow-up thyroid level that kind of leads us to this diagnosis. It can be tricky too as well, because the thyroid blocking antibodies can be present as well, and so sometimes you'll get a mixed picture in our neonates where they have some stimulating immunoglobulins, some blocking immunoglobulins, so they can have depending on when the immunoglobulins kind of dissipate from the baby's system, they can present with different symptoms. And then neonates, the symptoms include goiter, tachycardia, irritability, flushing, hypertension, eye disease, arrhythmia, and then can lead to cardiac failure and death as well. So, didn't cover, there's more emergencies obviously to endocrinology, but these are kind of the bread and butter ones that we probably see the most often. There's your code for your online people. So, happy to take any questions or this was more geared towards kind of the pediatric. So if there's anything from an adult standpoint that kind of differs, I'd love to hear it too, because adults and kids aren't the same. So yeah.
So two questions. One is when you are monitoring, which you don't, you only wait till the kids get there, but with adult Graves patients or post Graves or even Hashi patients, because with Hashimoto's also you could have a reversal of
going over there, right?
Yeah, I am.
Oh.
Yeah.
Oh,
you have the OB's comment on the neonatal.
what did you say?
I have to leave about 6:20.
Occasionally we do, but not always. Yeah.
And then the newborn screen in the state of Kentucky, I know.
You're leaving for there at 5 o'clock,
Yeah, if you're.
What are the unique, like,
and you'll drive. I could go with you,
tests that
but
they
then
do
when are you
on
going to come back?
At 6.
No, they do a TSH. Right?
Yeah, they do a TSH and with reflex, and so, but they check a lot of different things. Newborn screen, so like TSH, sickle cell. Nah. The newest one that got added,
But we won't get there till 5:30.
So it's like TSH, CH.
So you're going to stay an hour.
Adrenal leukodystrophy was added within the last couple of years, and so we've picked up a couple kids that way, where they're going to present with adrenal insufficiency and at quite a young age. And then it's a lot of metabolic, PKU and
I know.
acidurias. And
I was just curious about the. So the other comment I had was the immobilization. I just realized Zach, our second year fellow, did have an endocrine society case on a spinal cord injury patient from, I think it was an abscess, epidural abscess, tetraplegia, young woman with hypercalcemia who we followed. So he had a case report on that. They have an entity called, I think, immobilization related hypercalcemia.
nice.
So we hadn't seen one at all, and then we saw it.
Yeah, it's weird. I just haven't seen. I saw a lot my first year, and then then they all disappeared, and you're just like, well, what happened? And it seems like they just got better at moving them around, and I think that's
we
good.
gave her a dose of one dose of antidepressant.
Yeah.
And then she was fine after that.
We had a case not too long ago, and it's we see a lot of kids with like seizure disorders, and there was we've had a couple kids on the ketogenic diet.
Oh, yeah.
And we've had a couple that like have had like high calcium levels, and then like we did like a little bit of like the review, and there's some like reports of the ketogenic diet maybe like contributing to like a hypercalcemic state, and we're just like, but they also had like other comorbidities, and our question was always like, well, like, is it because of immobilization, which it didn't seem like, because the kid was kind of getting PT, doing all the normal stuff. And they're like, well, should we do Pamidronate? And then we were like, well, maybe like if it's from immobilization, then yes. But if it's from ketogenic diet, then
Change the diet.
that's what we said. But
I
they
know
can't go
it's
up.
become popular now for a lot of.
Yeah.
Let me just see if there's any questions.
Yeah.
Close the chapter.
All right, let's see if there's some chats. I got a question from Philip May. Do you screen for vitamin D deficiency? That's a broad question. And what setting? Like yes? Not on like the.
You don't routinely skip treatment, right?
When they come to me, I mean, usually they come with a vitamin D level most of the time. We screen for it. We have a metabolic bone clinic on the pediatric side, and so we're getting vitamin D levels because we're seeing kids with recurrent fractures, and so we're trying to optimize their vitamin D. But gosh, I think it's probably similar in the adult. I feel like everybody has vitamin D insufficiency or deficiency to some degree, and probably everybody needs to be on some vitamin D a little bit. And then like all our obese, like we see a ton of obese kids, and they seem to be all vitamin D deficient. And whether it's like true deficiency, or are they just like storing it in their fat, or like what's the clinical correlation of, we see a lot of people with low vitamin D levels, but they don't have rickets. Like, it's interesting. We also see a lot of rickets and on the kid side. So I think it's with the recent push in breast is best and breastfeeding, breast is best. It just doesn't have vitamin D in the breast milk, and so they're not getting vitamin D supplementation, and so they'll come to see us and have some bowing in their legs and failure to thrive. And so it's an interesting phenomenon because I trained in Florida, so I didn't see any nutritional rickets in my fellowship. And I've chalked it up now just because I'm in it's a sunny state and they must be getting it through the sun. And then moving up here, it's just a lot.
So is there a separate, for the emergency hypercortisone?
Mm-hmm.
For pediatrics, is there a separate?
Yeah, I think this is one, we call it it's called the Actovial. Is it the same for you guys?
Same as
it's a plunger, so it's the powder in the bottom, has the little the bladder and then the liquid on top, and you have to break it, shake it up, and then we give them a 1 cc syringe. And then there's different doses we tend to use. Like if they're less than 1 year of age, we're using 25 milligrams. If they're 1 to 10 years of age, it's 50 milligrams, and then anything above 10 years of age, we're using 100. And so that gets you close to that stress, severe illness type dose, where it's 100 mg per kg, 100 mg per kg. Just using average body surface area of a neonate is 0.2. So then if you're giving 25, you're getting close to 100. Average body surface area of a 10-year-old is 1, so you're getting close to there. So that's always a tip to use. We teach our pediatric residents that if you're in the emergency room and you're not going to be able to get a body surface area. They're just there and sick, and you're just looking at them, and you get a history that they might have been on long-term steroids of some kind. You got to give them steroids. What dose? You can use that 25, 50, or 100 dose to guess. But we honestly the more the better. If you don't know, give more, and then there's not going to be an issue. The only problem is if you give too little and you're not adequately treating their adrenal crisis. I got one call in fellowship where the pharmacist was mad at me because it was a kid came in, I can't remember what for, but the ED gave them some dose of hydrocortisone, and they're like, oh my gosh, this dose was too much. I was like, well, they lived, so it wasn't too much. This is the dose that they need. It's fine.
Have kids where you're giving them standard doses once they are out of the ICU, in the clinic, and they come back with some symptoms of insufficiency. Do you wonder about compliance, or are you looking into other areas like resistance?
Sometimes we've seen kids that we wonder whether it's withdrawal, adrenal withdrawal symptoms versus true adrenal symptoms. And so, depending on how long they were on stress dose steroids for. I feel for our our Addisonian type kids, they tolerate the wean better. But the kids we see a lot of kids that for their cancer, they're treated with a gram of Solumedrol for a month, and then they don't always get weaned on the ped side. And so they'll come in a couple of days later and, their symptoms kind of look like chemotherapy type symptoms, but it's probably adrenal, like they probably have an adrenal insufficiency, but they could just be having adrenal withdrawal too, because like you go from a gram of Solu-Medrol to nothing, like you're gonna feel bad. And so sometimes I've had a couple of kids where it seems like even their metabolism. So we have a couple kids with non-classic or a non-salt wasting CAH that got picked up later in life, and he was never cushingoid, but like his milligrams per meter squared dose of hydrocortisone was just like way higher than you would expect, and it was a great family, and I had no like concerns that.
I think some of them just clear it faster than.
Yeah, they're just metabolizing it a little bit differently.
Genetics.
Yeah. So we see that from time to time. Our biggest thing is usually like it's always the question about the adrenal withdrawal symptoms versus true insufficiency. So, and obviously we don't want them to feel terrible, but.
Thank you.
Thank you guys.